Hello everyone, I'm Sushmitha presenting a case of orbital compression syndrome due to orbital cellulitis. Orbital compartment syndrome is a rare condition caused by increase in intraorbital pressure due to orbital bleeding secondary to trauma or surgery or infection. I am presenting a 74-year-old male who came in with right eye swelling since 3 days followed by redness, purulent discharge and pain on eye movement. Due to increase in the severity of symptoms, he was brought to the ED by his friend. He was unsure of changes in vision as his eyelids were completely shut. He denied any history of trauma, insect bite, peripheral edema, or any other symptoms. Vitals were stable on admission. He had severe edema, redness, and induration on right upper and lower eyelids on examination. He had afferent pupillary defect on the right eye and no light perception. Lab results showed WBC count of 14,000. CT orbit showed significant right and mild left periorbital soft tissue swelling without postseptal extension as shown in the figure 1. And air fluid levels in paranasal sinuses as shown in the CT scan figure 2. MR venography did not reveal any evidence of venous thrombosis. Abscess fluid was collected for culture. He was started on Unicin, vancomycin, and amphotericin until culture results were obtained. Ophthalmology was consulted, who started him on intraocular pressure lowering drugs. They performed right upper lid incision and drainage, canthotomy, and cantholysis of right lateral canthus to decrease the intraorbital pressure. Tissue cultures were also obtained. As patient did not improve and eye pressures increased, they performed orbitotomy and exploration with tissue biopsy along with incision and drainage of abscess in the right upper eyelid. They also performed a revised canthotomy and cantholysis of right lateral canthus to further decrease the intraorbital pressure. Cultures confirmed MRSA. IV vancomycin was continued. Swelling and pain improved, however, right eye vision could not be recovered. He was discharged on Bactrim for 14 days and to follow up in outpatient in 2 weeks. Adult orbit has a fixed volume, limited elasticity, and compliance of the septum and tarsal plates. Hence, any increase in the intraorbital pressure will lead to irreversible vision loss due to optic nerve damage from prolonged ischemia. Most common cause of orbital compartment syndrome is hemorrhage secondary to trauma. Orbital compartment syndrome due to orbital cellulitis is an unusual presentation. Orbital cellulitis is an infection involving the contents of the orbit, and it is often confused with preseptal cellulitis. Preseptal cellulitis is the infection that occurs in the soft tissues anterior to the orbital septum, and orbital cellulitis is infection posterior to it. Preseptal cellulitis is generally a mild condition that rarely leads to serious complications, whereas orbital cellulitis may cause loss of vision and even loss of life. Hence, identification of orbital cellulitis at a very early stage is very important. Orbital cellulitis can be distinguished from preseptal cellulitis by its clinical features such as ophthalmoplegia, pain with eye movements, and proptosis, along with imaging studies. The most common underlying factor that leads to orbital cellulitis is acute sinusitis. Empiric antibiotics should be initiated until the culture results become available. In summary, the diagnosis of orbital compartment syndrome is completely clinical. Early identification and urgent orbital decompression even before imaging is essential to prevent permanent vision loss. Sampling of orbital content for microbiology and treatment with antibiotics along with surgery to treat the underlying cause is the mainstay of treatment in these patients. Thank you.